Hi everyone. Today we'll move on with the topic the physiology of normal labor and pain relief. Now, in normal labor, during pregnancy, what happens is the fetus and the uterus will undergo hypertrophy as well as hyperplasia. So, in the entire pregnancy, uterus remains in a quiescent stage. Progesterone is a smooth muscle relaxant, and in the entire pregnancy, progesterone predominates. But in the labor, estrogen predominates. In the physiology of labor, the fetal hypothalamic axis matures. It leads to the release of fetal CRH, that is corticotropin releasing hormone, from the fetal hypothalamus. Now, this fetal CRH will initiate the labor. Let's see how. The fetal CRH will stimulate the fetal pituitary to release fetal ACTH, that is adrenocorticotropic hormone. Now, this adrenocorticotropic hormone released from the fetal cells will stimulate the fetal adrenals to produce main product, that is DHEA sulfate, dihydroepiandrosterone dione sulfate. It also produces a cortisol as a byproduct. Now, this fetal DHEA sulfate will act upon the placenta to release estrogen. As I said, estrogen is a predominant in labor. What is the function of fetal cortisol? The fetal cortisol will stimulate the placenta to release placental CRH. Now, this placental CRH will be helping in producing full form placenta. That is, they will be releasing prostaglandins, interleukin 6 and 8, and stimulate the production of fetal cortisol. There is a positive feedback. This placental CRH is produced by stimulated by fetal cortisol. Now, this placental CRH again stimulate the production of fetal cortisol. It is an example of positive feedback. Now, what does the estrogen do? Will the main source of estrogen, as we said, it is fetal DHEA sulfate, and the most common in estrogen in pregnancy is E2. The most specific estrogen in pregnancy is E3. The placental CRH also acts on the uterus as well as the fetal membrane. It acts on the fetal membrane to release prostaglandin E2. It acts on the uterus and stimulate the decidua to release PGF2 alpha. It upregulates oxytocin, estrogen, and stretch receptors, but it downregulates progesterone receptor. But you have to be very careful here. It doesn't increase the level or decrease the level of the hormones. It upregulates and downregulates the receptors. Due to the upregulation of the oxytocin receptor, there is increased in uterine contraction because of increased intracellular calcium. The muscle fiber of the uterus act in a coordinated manner, and the myometrial gap junctions increase. These are done by prostaglandins. Prostaglandins also lead to softening of cervix, also called as ripening of cervix. It increases the water content and the collagen breaks down occurs. Ripening of cervix. So there is increase in hyaluronic acid and decrease in collagen and dermatone sulfate. It is mediated by prostaglandins, as I said. So it starts before true labor pain begins. What events happen before onset of labor? Lightening, cervical ripening, and false labor pain. What is lightening? For example, see, this is the a pregnant woman. Here is a xiphisternum, and at 36 weeks, the fetus develops and the uterus touches the xiphisternum. It causes respiratory discomfort to women at 36 weeks. But after 36 weeks, there is a descent. The fetal head descends into the pelvis. So there is a relief of respiratory discomfort. That we call it as welcome sign or lightening. So for labor, we actually need three P's. The first P is passage, that is the pelvis. Second P is passenger, that is the fetus. And third P is push, that is the uterine contraction. Now we'll move on to uterine contraction. So as a heart beats, there is a pacemaker. The uterus also needs a pacemaker. That is situated in the corner of the uterus. Preferably, the contraction start at the right, then the left. It spread to the entire uterus. The entire uterus is depolarized in 15 seconds. The contraction are predominantly in the fundus of the uterus. So we'll see the values of intensity, that is the pressure, Braxton Hicks contraction, that is a false labor pain. What is the pressure? That is less than 8 millimeters of mercury. Contractions are palpable when the pressure is 10 millimeters of mercury. The contractions are painful and cervical dilatation begins when there is the level of 15 millimeters mercury. Fundus cannot be indented if in the moderate pressure of 40 millimeters mercury. Normal uterine contraction. Uterine contraction occurs in a coordinated manner. It leads to progressive dilatation of the cervix. It has a polarity. Upper part of the uterus, that is upper uterine segment contracts, the upper uterine segment contracts, and the lower uterine segment will be relaxing. It leads to descent of the fetal head. So if there is pressure in the fundus and there is relaxation in the lower segment, then it will be pushing the uterus downwards. The contraction spreads from the upper part to the lower part of the uterus. As it spreads, its intensity decreases. It's obvious. What are the parameters of uterine contraction? When the uterus relaxes during labor in between contraction, the pressure is 20 millimeters of mercury. It is called as the basal tone. What is the peak pressure? It is 80 millimeters of mercury. Uterine contractions are followed by relaxation. Relaxation is important because at time of contraction, the blood flow to the fetus decreases. If if it undergoes tetanic contraction, what will be happening? There will be fetal distress because the blood flow decreases. So relaxation is necessary. At the time of relaxation, the blood flow is restored. So if this is the muscle fiber, the initial length of the muscle fiber, if it contracts and relaxes, it doesn't relax it to its initial state. This we call it as retraction. Adequate uterine contraction. So if three contraction in 10 minutes, that is the frequency. Each contraction should last for 45 seconds and the pressure should be 65 to 75 millimeters of mercury, that is the intensity. So these three things should be necessary for a adequate uterine contraction: frequency, duration, and intensity, that is the pressure. What is tachysystole? Tachysystole is greater than 5 contraction in 10 minutes. It can be spontaneous or induced. Tachysystole cause fetal distress. There is a term that is called as hyperstimulation for this. Units for measuring uterine contraction: millimeters of mercury, and there is another unit that is called as MV unit, Montevideo units. Montevideo units, you have to obtain Montevideo units, you have to just multiply the pressure, that is the intensity, with the number of contractions in 10 minutes. So let's say if the pressure is 65 and the number of contraction in 10 minutes is 3, you have to multiply both to get the answer. Now let's see the nerve supply. This is the uterus. The uterus is supplied by T10 to L1 via the hypogastric plexus. The cervix and the upper vagina. The cervix and the upper vagina is supplied by S2 to S4 via the sacral plexus or the pelvic plexus. The lower vagina and the perineum is supplied by the same S2 to S4 but via the pudendal nerve. What is the pain during labor? So in the first stage, we divide the first stage into the latent phase and the active phase. And second stage, pain. The first stage, in the latent phase, the pain is due to uterine contractions. It is at the level of T10 to L1. In the first stage latent phase, it is due to the active phase, it is due to dilatation of cervix that is carried by S2 to S4 sacral plexus. In the second stage, the pain is due to stretching of the lower vagina and perineum. It is carried by the pudendal nerve. The nerve root value is S2 to S4. For pain relief in labor, we follow parental drugs to provide pain relief, regional blocks that are paracervical block and pudendal nerve block, and neuraxial block that is epidural block. What are the parental drugs used to relieve the pain? Meperidine 50 to 100 mg IM and promethazine 25 mg IM. Remember these two drugs, meperidine and promethazine. Maximum effect is seen in 45 to 60 minutes. Effect lasts for 4 hours. If they are given an IV, there is higher chances of developing aspiration, nausea, vomiting, respiratory depression in fetus, lower Apgar score, especially if used in the second stage of labor. Now we'll move on to the blocks. Paracervical block. It is a regional block. Block pelvic plexus which carry pain sensation from cervix to spinal cord. Where it is given? It is given in the lateral fornix. It is given in 2 to 4 o'clock position or 10 to 8 o'clock position, not in the midline. That is 3 to 9 o'clock position, not in here. Why? Because there is descending cervical artery present over there. You should use a spinal needle of 22 gauge. What is the drug use? That is lidocaine, 1% of 5 to 10 ml on each side. Maximum you can give 250 mg or 25 ml totally. What are the disadvantages? It is short acting. 15% of the cases may go to fetal bradycardia. If the cervical artery is injured, there will be vasospasm. Blocks only pain from cervix and not by the pudendal nerve. Why it has to block the pudendal nerve? It's obvious, right? Paracervical block, as I said, these root values. Pudendal nerve carries S2 to S4 and the lower vagina and perineum. The pain via this segment, which occurs in the second stage of labor, is carried via the pudendal nerve. Pudendal nerve has no role over there. Okay, it is used in the first stage, also used to repair cervical tear. Now moving on to the pudendal nerve block. So obviously, as the name suggests, we have to block the pudendal nerve. The site is the ischial spine. They can even ask image-based diagrams based on this. What are the ligament pairs? That is sacrospinous ligament. Drug is same as paracervical, that is lidocaine. It is better than paracervical. Why it is better? Because it can be used in the second stage of labor and it can be used in the instrumental delivery and perineal and vaginal tear repair. It is not used in the first stage of labor and cervical tear repair. Paracervical block is used here. Now moving on to the epidural block. It is not a regional block, it is a neuraxial block. It is best for painless labor. It blocks at a upper level, that is T10. It blocks the sensory and sympathetic component. There is it doesn't block the motor component because motor is essential for the contractions and the progression of labor. There is vasodilatation. Due to this vasodilatation, there is development of hypotension in mother. It does not block the motor, as I said. Drug of choice is bupivacaine here. The concentration is very important. It should be in the range of 0.625 to 0.1 percentage. If the dose is higher or the concentration is higher, there will be blockage to the motor component. It is very dangerous. So the concentration you give is very important. It can be used in first stage as well as second stage. What are the effects of the epidural block? It shortens the first stage, it prolongs the second stage by 1 hour. It doesn't increase the chance of C-section. That's a myth. It doesn't increase the chance of C-section. Maternal hypotension, as I said, maternal hypotension leads to decreased placental perfusion and may lead to transient fetal bradycardia. If there is transient fetal bradycardia, you have to immediately start IV fluid and place the patient in left lateral position. If not relief, give phenylephrine. What are the contraindication to epidural? Hypovolemia or severe hemorrhage. It is an absolute contraindication. Increased intracranial tension, local infections, severe thrombocytopenia, that is less than 50,000. Fixed cardiac output state. In case of severe MS and AS, this is a relative contraindication. What is the level for C-section? It is even higher for C-section. That is T4, not T10. To block the peritoneum, some patient may develop fever after epidural analgesia. Okay, thank you.